position for palpation, percussion, and auscultation. You can use also sitting positions or high Fowler's position if the patient is unable to tolerate supine position. Instruct the patient that you are going to palpate the sternum, ribs, and intercostal spaces. Locate the suprasternal notch, palpate downward to the sternal angle or Lewis, where the manubrium meets the body of the sternum. If the patient is obese, patient may be unable to lie flat during this assessment. Yes, very true. So this is how you do the respiratory expansion, the anterior view. Again, for this is nice to know. During your practicum, you do not need to do the anterior view. You only do the posterior view. When you percuss the anterior thorax, which will yield a dull sound over a solidified or fluid of filled areas, like pleural effusion, consolidation of tumors, and those will be the areas that to percuss. This is the on the lateral side. Again, in real life, you don't do all of that. You just do the anterior part. The RN, once you become an advanced nurse practitioner, then of course you have to do all of them. This is the auscultatory sounds, anterior. This is what we mentioned. Remember that if you auscultate over the tracheal area, of course you are going to hear tracheal sounds. If you auscultate on the around the bronchus, you will hear a bronchial sound. And the bronchiovesicular, you can see it right on the sides of the breastbone right there. And of course, you can see most of the breath sounds that you will hear. It will be vesicular. See how many V's there are in there? Let me see if everybody is here. And everyone should be on camera. Brandon, are you there?
He went to the bathroom.
Oh, okay. Alex?
I'm here.
Okay, get yourself on camera, because if not, they told us just check, and if they are not, you don't have to tell them anything. Just remove the 30 minutes. And that. Okay. And if they ask, you just say, I couldn't see you on camera. So, Yvette, are you there? Okay, you cannot be laying down. You have to sit up in the chair, and you need to be seen.
I was reading my book, but I could sit up.
Okay, good. Alrighty, so let's go over. Again, you are not expected to percuss on the sides but just the posterior. And we were saying that the most frequent auscultatory sounds that you will see or hear are the vesicular. These are normal and abnormal respiratory rates and patterns. Eupnea is the normal breathing, which is when it is normal, there is even depth, regular pattern. Inspiration is equal to expiration, and there is an occasional sigh. And this is the way you will see it if you were seeing it on the monitor. And in here, in the second picture, you see eupnea with sigh. And breathing, I'm sorry, not breathing, but what did you say? Sighing frequently is considered abnormal, but one sigh is not abnormal, but frequent sighing is considered abnormal breathing. You need to know the term tachypnea. which means rapid shallow respirations, and the rate is greater than 24. Precipitating factors, tachypnea could be due because the patient has fever, patient is afraid, the person who just finished exercising, or there is respiratory insufficiency, or pleuritic pain, or alkalosis, or pneumonia. And tachypnea is considered abnormal. And you see, if you were looking at the monitor, this is the way it would look, the pattern. It would be very rapid, even, but rapid. We still with the normal and abnormal respiratory rates and patterns. Biots is considered ataxic respirations, and you can see the pattern there. Frequent signs, precipitating factors due to hyperventilation syndrome. The person is nervous, and it causes, if the person sighs frequently, it will cause dyspnea or dizziness. Obstructive breathing usually is due to COPD, asthma, chronic bronchitis. Let's see, what is, I told you. Oh, I missed this one. Know the term bradypnea, which is slow, regular respirations, but the rate is less than 10, so that means really bad. See? Precipitating factors, diabetic coma, drug-induced respiratory depression, increased intracranial pressure. No bradypnea and no Cheyne-Stokes. Hyperventilation is rapid deep respirations greater than 24, and the precipitating factors are extreme exertion, fear, diabetic ketoacidosis, or Kussmaul's breathing is also called, hypoxia, salicylate overdose is aspirin overdose, and hypoglycemia. Hypoventilation is irregular, shallow respirations. The rate is less than 2. Precipitating factors, narcotic overdose, anesthetics, prolonged bed rest, chest splinting. No Cheyne-Stokes, periods of deep breathing alternated with periods of apnea. The pattern is regular. Precipitating factors, normal in children and aging. Heart failure, uremia, brain damage, drug-induced respiratory depression. Cheyne-Stokes is not a good sign to have. Okay, so remember how we said the adult chest is elliptic in shape with the lateral diameter that is larger than the anteroposterior diameter in a 2-to-1 ratio. Don't get confused with this picture because just they are saying they are utilizing the different word that they are utilizing at the beginning when we mentioned. The normal should be 1-to-2, but this, because they are listing it in a different way, that's the way it says there. But this is the normal way that it should look. Nothing with the child or the infant. Barrel chest, no barrel chest. The anterior posterior diameter is equal to the lateral diameter and the ribs are horizontal. A barrel chest occurs normally with aging and accompanies COPD. See how the front, it is as wide as the on the side? It shouldn't be, the side should be smaller than the front. So barrel chest is not abnormal, it's an abnormal configuration. It is typically of COPDs or persons who are older. Although not every person that is older develops this. It depends if they keep in shape, you know. Funnel chest, pectus excavatum, nothing on the child or the infant, but no scoliosis, which is a condition in which there is lateral curvature and rotation of the thoracic and lumbar spine. It occurs more frequently in females. Scoliosis may result in elevation of the shoulder and pelvis. Deviation greater than 45 degrees may cause distortion of the lung, which results in decreased lung volume or difficulty and interpretation of findings from physical assessment. No kyphosis, which is an exaggerated posterior curvature of the thoracic spine. It is associated with aging. Severe kyphosis may decrease lung expansion and increase cardiac problems. Nothing on pigeon chest or pectus carinatum, nothing in there. The abnormal findings, we are going to go over the pictures. Asthma, no asthma, which is a chronic hyperreactive condition resulting in bronchospasms, mucosal edema, and increased mucus secretion. It occurs in response to inhaled irritants or allergens. And you can see in the picture how, when there is the bronchospasms, how the mucosal edema, it is represented in there. Look at the alveoli, how inflamed they look, or edematosis. You can see the mucus inside of the so no asthma, no atelectasis, which is an obstruction of airflow. The alveoli or entire lung may collapse from airway obstruction, mucus plug, lack of surfactant, which is a complex substance that prevents collapsing of the lungs. On inspection, when you are trying to find out whether there is atelectasis, there is a decreased lung expansion on the affected side. There are increased respirations, dyspnea, cyanosis, and if it is severe, the trachea shifts to the affected side. On palpation, there is lack of remittance. On percussion, there is dullness over the affected area. On auscultation, there is a decrease or absent breath sounds and voice sounds. And you can see the obstruction right inside of the alveoli. Look at that. Bronchial obstruction or collapsed lung. No chronic bronchitis. Chronic bronchitis, chronic inflammation of the tracheobronchial tree leads to increased mucus production and blocked airways. A productive cough is present. Let's see, what is the... make sure that the key or the classic symptom with chronic bronchitis is productive cough. Productive means that they expectorate, they have a sputum. And of course, when the person is expectorating or has productive cough, you always have to ask what color it is, because that is significant. If it is clear, then it's not infectious. But if it is yellow, orange, green or kind of orangey yellow, then of course it's infected. On inspection, when the person has bronchitis, chronic bronchitis, there is dyspnea, chronic productive cough, tachypnea, and use of accessory muscles. Yeah, you always see accessory muscles. You expect to see accessory muscles, the use of accessory muscles because they are in distress. On palpation, there is normal tactile fremitus. On percussion, there is resonance. On auscultation, there are wheezes and bronchi may be present. And there are some other abnormal findings, which is the emphysema, pneumonia, pleural effusion. Okay, so let's go with the pictures. Emphysema. No emphysema, chronic inflammation of the lungs, which leads to the destruction of the alveoli and decreased elasticity of the lungs. As a result, the air is trapped and lungs hyperinflate. Inspection is shortness of breath on exertion, barrel chest, pursed lips breathing, which means they use the lips to breathe because they cannot breathe any other way. Use of accessory muscles, cyanosis, clubbing of the fingers, tripod posture, which means tripod posture means that in order for them to breathe, they have to have like the bedside table, that they have in the hospitals, and they have to position their hands on the table in order to breathe because they need a little help. There is decreased chest expansion, decreased tactile fremitus, and on percussion there is hyperresonance. Auscultation, there is decreased vesicular sounds and possible wheezes. And you can see how the lung is hyperinflated. There is a permanent enlargement of the alveoli with destruction of the septa. And there is also destruction of the alveolar walls. So you can imagine the people who have emphysema, they always have serious problems with breathing. And the last one that you need to know is lobar pneumonia, an infection that causes fluid, bacteria, and cellular debris to fill the alveoli. On inspection, there is tachypnea, productive cough, chills, palpation, increased tactile fremitus, decreased chest expansion on the affected side. On percussion, there is dullness of the affected area. On auscultation, bronchophony, egophony, whisper pectoralochi, bronchial breath sounds, and crackles. And you can see the consolidation due to alveoli filled with fluid, bacteria, red blood cells, and white blood cells. And then you see mucosal edema, and see inside of the alveoli, you can see fluid and mucosal edema. We still with abnormal sounds, pneumothorax, congestive heart failure, valley fever. So when there is pneumothorax, there is collapse of the lung. When there is congestive heart failure, there is edema around the alveoli. With valley fever, valley fever is a fungal infection caused by Coccidioides organism found in the soil, in construction, and also carried by the wind. And the signs and symptoms of valley fever are fever, chest pain and cough, chills, joint aches, and a spotty rash. And you can see the picture here. No pneumothorax too. I don't know if we mentioned air or not. I think, no, we mentioned atelectasis. With pneumothorax, air moves into the pleural spaces and causes partial, complete collapse of the lung. Pneumothorax can be spontaneous, traumatic, or tension. On inspection, you will see tachypnea, decreased expansion of the chest wall on the affected side. There is a tracheal shift on the unaffected side. Palpation, there is decreased tactile fremitus. On percussion, there is hyperresonance. On auscultation, breath sounds and voice sounds are decreased or absent. And you see how the lung is collapsing here due to air entry. And the air entry could be caused by a bullet, a knifing, because what happens is the negative pressure in there, by having an opening, it will equalize it, and then it will become the lung will collapse because of the change in the air. Air fills pleural space following chest trauma or lung rupture. And you can see what happens to the, when there is pneumothorax, what happens to the alveola. It compresses. So it's very serious. Left, I think we are just about to finish. Left heart failure. And one of the, let's see, what is the key word on this? Left heart failure, classic symptom, write it down, know this, is hacking cough. Hacking cough. Left heart failure, there is increased pressure in the pulmonary veins caused by interstitial edema around the alveoli. It may cause edema of the bronchial mucosa. On inspection, there is increased respirations, SOB on exertion, orthopnea, sensation of breathlessness in the recumbent position. That's what it means, orthopnea. And it is treated or helped by the patient sitting up. Peripheral edema, it is found, as well as pallor. The skin is pale. On palpation, there is normal tactile parameters. On percussion, resonance. On auscultation, normal breath sounds and voice sounds, wheezes or crackles at the base of the lungs. And you can see the pulmonary congestion inside of the lung, and the possible edema of the bronchial mucosa, and pulmonary capillaries engorged, and deflated alveoli. Left CHF occurs when the heart is unable to pump sufficiently to maintain blood flow to meet varied needs. And they also have this hacking cough. When there is left heart failure, there is tiredness, shortness of breath, pulmonary edema, pumping action of the heart grows slower, swelling of the ankles and legs, pleural effusion, which means excessive fluid around the lungs, swelling in the abdomen, which means ascites. And that's it. Okay, that was the perfect timing for, because we have to go now to the, to do the quiz. Okay, so